caused by the corniculate, and here's the bump caused by the cuticle. You won't see it in the larger pure cartilage models because they don't put it there. So that brings us to our last cartilage, which is this leaf-like cartilage right here, attached to the anterior aspect of the thyroid cartilage. So it's attached in here. Actually going to go a bit higher, but so it's an epiglottic cartilage, but it's in the epiglottis, which is what we call the structure covered with membrane. So that says epiglottis there, but it should be the whole mucous membrane structure that is truly the epiglottis. The epi is over or above, and so this structure, when you swallow or cough, remember the suprahyoid muscles that would pull the hyoid bone up and the larynx with it? The epiglottis comes down and covers up the opening to the airway. All right, on page 18 and 19 are some muscles. These are all skeletal muscles. And they're all innervated by vagus. So the first one on your list is cricothyroid. It's most easily seen from a lateral view. You can see it on some of the models. Sorry, this one that you have. This lower one right here is cricothyroid. Okay, so it goes from the cricoid cartilage to the thyroid, and its function is to tilt the thyroid, the larynx forward. So when we tilt the larynx forward, there is a pair of ligaments that extend from the inside of the thyroid cartilage to the arytenoid. And these are the vocal ligaments. So as we tilt the thyroid cartilage forward, what's going to happen to the tension on those vocal ligaments? Is it going to go up or go down?
Go up.
It's going to go up. So what happens to pitch?
Higher.
It goes higher. So if you tighten the strings on a violin or guitar, the pitch goes higher. All right? So this is going to increase pitch. All right, the next muscle is the posterior cricoarytenoid. So that one's this one. It goes from the cricocartilage. It wraps around to attach to the arytenoid cartilages. And you can also see that muscle on this model. So that's this one right here. All right, and you can see its function if you pull on this, so, oh, I didn't do it hard enough. But this one's going to move, it's not going to move the cricoid, but it will move the arytenoid cartilages. And so this causes a separation of the arytenoids. All right, so it's going to abduct the arytenoid cartilage, or open the airway. Increases the amount of air that can go through the vocal ligaments. So if my fingers represent the vocal ligaments, it's going to do this. Okay? So two vocal ligaments, it's going to open that space as it turns the arytenoid cartilages. The lateral ones are a little bit easier to see, I think, on the neck. Yeah. So here the thyroid cartilage is in a cutaway. You're looking on the inside. So these are the lateral ones here on the inside. Let me do a different color. They're going to be from here. So between the thyroid and the cricoid cartilage laterally. So we're going to see them kind of like this. Whereas the posterior, we're doing this. So these are the lateral cricothyroids, and they do the opposite effect. They close.
Where are the attached again?
Let me show them to you on the model. I think they're on here. So there are these. If you look from the top down, they're going to be just inside, between right here. So here, posterior, coming from the back, and the laterals come from the side. Okay, so posterior, laterals are inside, on the side of the cricoid, coming from the inside of the cricoid, coming up to the arytenoids. So these are a good model to see those muscles, if you can look at them in just a minute a little bit during lap. Okay, the next two muscles just connect the the arytenoids. So I'm going to do them in green as well. So we have our muscle up here. And we have transverse arytenoids. These always remind me like a barn gate or door or something. So we have the transverse arytenoids. And then crisscrossing them, we have the oblique. They both have the same function. So transverse and oblique arytenoids. And they also abduct. AD. They open up the space. And then finally, we have the vocal ligament, the vocal muscles, called vocalis. So I'll show these to you in the diagram in just a second. Vocalis covers up the vocal ligaments. And it's going to do the opposite of cricothyroid. It's an antagonist to cricothyroid. So remember, it's going from thyroid to arytenoid. So it's going to pull those two structures together. It's going to decrease tension and decrease pitch. So it'll lower the voice. Yes.
So are the muscles that you drew between the two arytenoids, are they the same muscle? Because I'm only seeing one of them up there.
Well, there's the transverse are the green,
Okay.
and the obliques are the blue,
And those are, oh,
the
okay.
arytenoids. All right, so first of all, let's go back to that model here. You can see a couple of them here. These would be the posterior cricoarytenoids here. Okay. They're the only ones that, sorry, the lateral ones are the only ones that do the ejection. These are going to AV duct or open up the airway, as are these. So here's the transverse, and here are the obliques on crossing half of the arytenoids. And they also do abduction. So here's the lateral coming up, and you can see the posterior here. So we had to cut away the thyroid cartilage to be able to see the lateral. The lateral comes from the inside of the cricoid and attaches to the arytenoid, and they're the only ones that close or bring the vocal ligaments close together. The posterior and the arytenoids are going to abduct or open them. All right, so cricothyroid, posterior cricoarytenoid, transverse, and oblique. And then as we look down inside, not these muscles out here, but the most medial ones are the vocalis muscles. So this diagram kind of shows you a little more clearly by isolating the muscles what their functions are. So you can see the cricothyroid tilting, creating an increased space and tension on the vocal muscles. The posterior cricothyroid opening, and the lateral closing, and the vocalis connecting them like that. Another view here. All right, and before we'll come back and do nerves. Well, yeah, that's a little bit more drawing-wise extended. So this is a coronal section through the larynx. And here where the vocal ligaments are in this space here. And there is another fold just above them, all right? So, see if I have, here we go. So on this model, this is that same model, but cut in section. Here's the thyroid cartilage. Here's the epiglottic cartilage. Here's the thyroid. This is cricoid and this is cricoid. Remember, cricoid is small in the front and large in the back. And we only have thyroid on the front because it's open and absent in the back. Okay, that explains the blue structures. Now, you can see that there is a kind of an indentation, a shelf-like area here with a fold above and a fold below. Those are known as the false and true vocal folds. Within them, also the vestibular and ventricular. Okay? Within them are ligaments, the false vocal cords and true vocal cords. We have fold, which is the mucous membrane over it, and the actual ligament. The reason this is the true is because this vibrates to create your voice. The false does not. Right? Its purpose, its thought, is really to be just kind of a protection for the true, to catch anything that might be inhaled into the airway. So with that in mind, if we go back to this diagram from the coronal view, that was the sagittal view, here would be the vestibular fold or false, and this would be the ventricular fold or true. Go ahead and take a picture of that, and I'm just going to make a diagram of half of this and show you where the vocal ligaments and the vocalis muscle are. And then we'll take a break.
Joe, are you done?
Actually, let me finish the vagus nerve, and then we'll take a break as well as do lab. So have a break in 5 minutes and then lab.
It just has this out of the way.
No, it's blocked.
Anyone else? So this is the false vocal fold. So the fold means it includes the ligament and the mucous membrane over it. So within the true vocal fold, we're going to have the vocal ligaments. So these would be the true vocal ligaments. Those structures that I drew on the previous diagram. And around them, we have the vocalis muscle. Which functions to decrease tension. You can also see these folds on the sagittal head section. So in here, there are two muscles shown, but only one white band, and that's in the bottom one. So the muscle in the top one is an area epiglottic muscle, but the bottom one is the vocalis muscle. That's the only one that you need to know, associated with the true vocal ligament. Anybody remember, and you will in bits and pieces, what are the cranial nerves associated with speech? So I've already given you one, right?
The facial?
Vagus.
Oh, use that one. So tongue. God, if you're trying to talk without your tongue, it's a little hard to. So hypoglossal.
What do you include glossopharyngeal?
Glossopharyngeal would be there for sensory, but we don't need it for speech itself.
What else did
Facial?
Facial. Why would you use facial?
Huge
To move your lips, so I can talk like this, I move my tongue around, but if I move my lips as well, then it's going to be a lot easier.
Only were there.
Okay. So those are the primary ones involved with speech. Hypoglossal for tongue movement. You could probably include trigeminal. I'm going to put that in parentheses.
Open.
Why would I have trigeminal up there? To move your jaw. Okay. We have parts of trigeminal and parts of cervical nerves to lower it, but trigeminal is going to, we need it to raise it. So usually when you talk, you are moving your jaw to some extent. But you could try to do it with just the tongue and lips. And then we need vagus to create the airway movement and the vibration of the vocal cords. All right, so let's take a look at the pattern of vagus. Let's see which of these you have in your lecture notes. Got that one. All right. Can I erase the board? You guys have most of that on the picture. So vagus is coming out of the jugular foramen. All right, it's cranial nerve 11. And we know it as extending, it does sensory to the throat, a little bit of the middle ear, tympanic membrane. But then it travels down into our ventral cavities and innervates smooth muscle of the lungs, heart, we talked about for decreasing heart rate, and moves down into the abdominal cavity where we'll look at it in our last unit where it has activity with pancreas and stomach and so on. However, before it gets to that area, it sends off a couple of branches to the larynx. So in this region, we just call it vagus. And then it sends off a branch which pierces the thyrohyoid ligament. That's why I put it up there in the first place. So here's our cartilage, rather our hyoid bone. And our cricoid.
Is that rain? Sounds really loud.
So this branch is known as the superior laryngeal. And it divides into two. The one that pierces the thyrohyoid ligament is known as the internal. Now, to be correct, it would be the internal laryngeal branch of the superior laryngeal nerve. You may just call it the internal laryngeal nerve. That is sensory only. To the area of the larynx above the vocal cords. The external laryngeal nerve is motor only. To the cricothyroid muscle. That's the only muscle it innervates. So we can only on our models, the small larynx model, you can, whoops, actually, does it work? Thanks, Zoe. So here on the side, you can't see the external laryngeal nerve innervating the cricothyroid muscle here, but there's the internal laryngeal nerve where it's penetrating thyrohyoid ligament. Okay. It's going to go inside and innervate the inside the epiglottis, the inside of the upper larynx region. Then the rest of the vagus travels down the side of the neck. Going to pick up phrenic and travel with that for a ways, and gets into the thoracic cavity. So as it goes down into the thoracic cavity, about the level of the subclavian, another branch comes off and returns back to the neck region. So this branch that returns is identified as recurrent laryngeal nerve. So those are the two direct branches off of vagus. And the recurrent laryngeal nerve is seen on the posterior aspect of the trachea, this yellow nerve right here. And it is both motor and sensory. You can also see it on the back of this model, right here, which is motor and sensory. So recurrent laryngeal nerve. It is sensory to below the vocal ligaments. And motor to all of the other muscles that we described. So all the arytenoids, the posterior cricothyroid, the lateral cricothyroid, and the vocalis muscles. So motor to all other. Now, an interesting anatomical or structural event is, here's the recurrent. Here's superior, internal, and external laryngeal. Okay? On the right side, the loop that is occurring here for the recurrent laryngeal nerve is around the subclavian vessels. So it's going to go up around the right subclavian artery and back up into the right side of the neck. On the left side, instead of going, remember the subclavian comes off a little bit farther to the left without the brachiocephalic trunk. So on the left side, the loop of the recurrent laryngeal is actually around the arch of the aorta. So it creates a significant phenomena where someone could have an aortic aneurysm. So a thinning and ballooning of the aortic wall. There's a lot of pressure that close to the heart. One of our former lab techs, her mom had a 10-centimeter aneurysm in the arch of her aorta. That's a little less than 5 inches and in diameter. And that can cause pressure, stretching obviously, of the recurrent laryngeal nerve. Sign, symptom, hoarseness. So the hoarseness up here, the physician looks, the vocal cords look fine, no problem. You go home and rest your voice a bit when the problem is actually down in the chest with an increasing diameter of the aorta, which is obviously an emergency situation if it ruptures. Okay, let's stop there, and we'll take a break till quarter of 10 of, so you could have opportunity to look at the head models and the laryngeal models, find these muscles and examples of the vagus nerve. And then we'll come back and look at the airway, the trachea and bronchi, and so on. Talk to you about it.